body shear already. Is that right? So what is your preference? All prostate you do only HoLEP? What is your preference? All prostate you do HoLEP or you do flap or bipolar TRP also you do something else?
I don't do TRP for 23 years.
Okay.
So not TRP.
Alright.
This is not giving me much pleasure.
I have thought actually.
Somehow in the other side.
And I'm proud of the તારે જગ્યા રે અને એમને બી વાયર વચ્ચે ના આવે તો
No.
everybody says
Give me the chair. Give me the chair.
yeah. That's what I said. So no, I think it'll start. Then all prostate you do HoLEP only.
Yes, HoLEP, bladder dissection, midline enucleation if you want self-ejaculation, but no, I don't do any other. Can you find this on my back?
Yeah, there's one inside.
Now, this is might be not be useful, so give it on the side. Perfect. Now the camera system, we need to check that the camera is totally the wetness on the camera. Bring it out. Yeah, but it will get wet. Let's try to bring it out. Here. Check. This is the one. Okay, you want to start. Okay, perfect. So, in order to push the instrument in, carefully pull this to the sides. Okay, so then you put the instrument. Now, this is the camera. This is the water. This is the cable. Okay. Now. So who is going to be in charge of the water?
Vijay, okay, Bob? Vijay, come on.
Okay, no mobile phone. Always ready. There is some resistance here. Do you have office or? You have an office? Hello.
Hello.
Yes.
Yeah, good morning. This is for the August audience, day 2 of AIE. First, I'd like to give a post-op follow-up of yesterday. All 9 patients are doing okay. They are like RIRS, HoLEPs. All patients are doing good. So that is the first follow-up that we'd like to give. And now we are beginning day 2.
Thank you.
Professor Gomez is already ready with a HoLEP case, and I think we'd like to present the case. Parallel, I think the other cases will go on, but here, as we are ready, we'd like to first present the case. Akash will do that.
Thank you, Mommy.
Patient is 78-year-old gentleman who presented to us with chief complaint of acute urinary retention since 15 days, for which we kept a 16 PUC. Patient had voiding difficulty since 1 month. On blood investigation, patient was found to have PS of 2.87 nanogram per ml, and on ultrasound we found patient to have 70 gram per with 15 mm median low. Then is HoLEP, which will be demonstrated by Dr. Fernando Gómez-Sancha.
And OT coordinator will be there. He's just, I think, coming. But I think, yeah, Professor Gomez, you are on, sir. Yeah, you can,
We can
talk.
start.
Yes.
So thank you, everybody. Good morning, and hopefully I'm going to try to show the envelope technique again, which sparked some interest yesterday, and I'm going to try to see if we can avoid problems, like technical problems from yesterday.
Professor Anil Vajna is there. He's going to coordinate the case.
Okay, give me more jelly, please.
Hello, very good morning, friends. I'm really happy that I'm here at AIE And thanks to Kandarp and all his team to have organized this wonderful workshop, and really it's a proud privilege that we have Professor Gómez-Fernando. He is
Dr. Varshney.
Yes sir, good morning.
Anand here. 1 second please hold on. We are just inviting your moderators.
Okay.
Just give us 1 minute, sir.
Please go ahead. See that Professor Gómez-Fernando is here in India. He is from Spain, and he is going to demonstrate HoLEP in this particular patient. And I think you have heard the history. History has been taught to them.
Yes, it is safe.
So this is usual history that patients they develop acute retention, they are catheterized. Do you have endoscopic view on?
Yes.
Okay, so you can see this is a moderate sized gland. Slight congestion is there because of retention and catheterization. And I was just telling you, Professor Gomez has done otis urethrotomy. You must have seen, and that is, I think, the most vital. I was discussing with him in the morning, and he had been doing earlier green light lasers. And he was the one who started doing later on enucleation with green light. And then today only I asked him, now you see the muck inside the bladder. Can you all appreciate that?
Yes, sir. Yes.
So this is because the patient had retention, catheterization, and this is all infected material. And though the patient is on antibiotics, but it is all doable.
Create normal.
This is Dr. Vimal Dixit.
Yes, Vimal.
Sir, wanted to ask whether Dr. Gomez performs otis in every case or in some specific case when he does cystoscopy and finds some urethra narrow or something.
So, sir, what is your take on this question?
I use otis when I have trouble entering, but not in every patient.
Yeah, so he is not using it in every patient. He is using only when he has trouble in entering the urethra. I think that is the fair statement, because you don't need it in every patient. Most of the patients who have been catheterized will have a good capacious urethra. But certain patients, because the anatomy is variable, you at times, but on table you must have otis urethrotom, optical urethrotom, all these things, metal dilators, just because that which urethra will oblige you and which urethra will not oblige you is something individualistic. So now I was just telling you that what we had a discussion with Professor Gomez in the morning, that why did he shift from green light to HoLEP. So he says that I started loving this procedure after having mastered this procedure. So that is the message I must give to all the youngsters, that green light is not the one which has kept the promise all over the world, and it is the enucleation. And the why from green light enucleation he has shifted to holmium enucleation. The reason is that the anatomical dissection is supreme as far as the holmium is concerned. So I am really happy that he is here, and he will be demonstrating holmium enucleation en bloc technique. Now en bloc is the one which has come up lately, because initially when Peter Gilling described the holmium, it was 3-lobe technique, and then it went to 2-lobe technique, and now it is 3-lobe. So this en bloc. So
Okay, so let's start by marking. You see the pillars of the sphincter here. You see the pillars. So I'm going to do a little mark on both sides, more or less here, and that's going to lead me to go to the 12 o'clock. This is what I call the white line. And the white line, you see, is protecting the sphincter. It's demarcating, sorry, all the water came to my feet. It's demarcating the limit between the sphincter and the adenoma, okay?
Yes.
This way we can have a nice reference of where is the limit. Of course, now I get closer to the proximal edge rather than to the distal edge. This is going to give us some very good orientation throughout the procedure, okay? So this is the first step of the operation, to mark the limit of the sphincter and the and the apex of the adenoma. Next, I'm going to go to the floor of the verumontanum here, lateral to the verumontanum, and here I'm going to do this line, and I'm going to do this progressive movement from medial to lateral, trying to enter the plane of dissection. There is a lot of, yesterday we didn't have time with all the hassle to discuss some issues. You see these lasers now, Moses and virtual basket, are giving us excellent dissection but simultaneous coagulation. So we are not able to see the beautiful plane anymore. You know, the beautiful plane was the plane that you could see when you did dissection with a classic Holmium. The classic Holmium produced a very big bubble. It gave us a lot of dissection, but it was sometimes difficult to dissect and coagulate at the same time. So this is the entry in one side. I don't usually spend too much time trying to coagulate bleeders because it's not so.
So do you have different settings for coagulation in cutting or same setting?
Say again? The settings?
Settings for coagulation and cutting, you are same or
No,
different?
no. I use virtual basket, which is similar to Moses. It's a pulse modulation, and I will explain today. This pulse modulation is very good. It's a double bubble. The double bubble will give us, the first bubble will give us the classic dissection that we got before with a classic Holmium. And the second bubble is going to give us the ability to reach further with our coagulation. You see, so the distance where we can coagulate is now much further, and we get much better first pass hemostasis. Okay, so here we have the other space. So instead of looking for the beautiful plane, I have, realized over time that you need to aim to see what I call the capsular plane. And the capsular plane has a different definition as the beautiful plane. The beautiful plane, I'm going to try to show you the beautiful plane in a moment. Let's see if I can show it to you using a little bit of mechanical dissection. Okay, so you see, if I come here and I do a little bit of mechanical dissection, normally we can start seeing the beautiful plane. The beautiful plane looks like this, you see? It looks like if it's covered by mucosa, the vessels are running more or less parallel to the surface, okay? But if we start developing this plane, you see the energy will spoil it. So we no longer see this plane anymore, huh? So I'm going to have to settle for another plane, and the definition of this plane, the capsular plane, is based on several factors. The first factor is that this plane is usually white or whiter than the adenoma. You see the adenoma has a yellow color, but the capsular plane usually has a more whiter color. It's also a smooth plane, and it's a plane that has fibrous structures in the surface. So when we look at the plane, it's more or less smooth. It's white. It's fibrous on the surface. Okay, so and also there's another factor. It's coherent. When we go from this side and we look at the other side, you see it looks like the same plane. So it gives us how do you say, confidence to see that it's a coherent. This is what I call a coherent plane. So basically, now we operate looking at this plane and deciding if it's a capsular plane or not. And there's another factor in the definition. The capsular plane is not perforated. If you perforate, of course, that's deeper than the capsular plane. Okay, so as you can see, I'm doing the posterior dissection initially. When we try to go up, we have difficulty because there is lateral fixation here and here, you see? So it's very difficult to try to go under the adenoma and try to aim to go to the bladder neck. So at some stage I will stop because the plane looks a little bit thin, and then we will change the position of the laser and the fiber to 12 o'clock. And my next step is going to go from 6 to 12 o'clock. Initially I will deepen the white line a little bit more because this is what I call an incision for access. Okay, when we do these incisions, we take the tissue a little bit apart, and that is going to give us a little bit better access to the lateral plane.
What are the current settings?
Settings, I'm using 250 with
Can you
virtual
see the
basket.
screen for the settings?
Second.
The energy and 50 frequency.
Yeah.
But I have to insist that the settings are not so important.
Okay, you don't change any settings anytime.
You know,
What
the
about
settings
the
are not
cases?
so important. I have to insist that it is the surgeon who is responsible to deliver the energy to the tissue. So even with the same settings, as I was trying to explain yesterday, you see, if you fire too far from the tissue, there is no effect. So the settings, you know, if you fire closer, you get coagulation effect. If you get even closer, then you get some disruption. Please, I'm going to ask you to keep silent in the operating room. I ask you dearly, please, don't speak in the operating room. Thank you.
Yeah, yesterday I also took about 2 to 50. And
Okay, so-
it is, yeah, I'm comfortable with the 2 to 50, but if the energy is not important, 2 and 30 is, are you okay with the 2 and 30?
The 30 is for coagulation, and there are two different settings. I use the
No, 50.
Magneto.
Okay.
There is the Magneto for coagulation. Okay, so you see, the problem before was that people would continue the dissection going up, going up, going up. But this would put a lot of stress on the sphincter, and the
It does.
mucosa would break here. Okay, so the sphincter was deepithelialized. So what we are trying to do is we're trying to ascend towards 12 very carefully, and making sure that we cut the apical tissue first. Okay, so here you see I'm trying to come, excuse me, I'm trying to come up to do this. I have very little freedom with this fiber. I cannot do what I want, sorry. I want to come from here, going up and cut the most distal part. So let's open some way here. This is what I call the access incision. It doesn't go looking for the plane, it just looks to remove the attachments from the sphincter and the apex of the prostate. So now I'm going to go a little bit further up. And you see, yesterday I was saying that enucleation detaches the capsule and the adenoma. But what we achieve with this detachment is to gain mobility. The mobility that we gain on the adenoma is going to help us gain access to places where we couldn't access before. And that is the idea. We're going to strategically do progressive detachment of the adenoma and the capsule in order to be able to have better and better access to where we want. This is the example of the palace I told you yesterday. When you go to a palace, you go to a room, and the room has a door on the other side of the room. When you cross the room, you open that door, you enter another room, okay? And this is how palaces work, and this is how HoLEP works. You need
So what?
Yes, go ahead.
What is your take on after early apical release? If you do more of blunt and less of laser dissection?
Well, in my experience, in my own data, when we did reline enucleation, we did a lot of blunt dissection. And blunt dissection caused more early stress incontinence. I think we have to minimize.
So after early apical release, once you already did the incision at the apex, then you do blunt dissection. What is your take on that?
Well, I try to avoid it. Because blunt dissection has the potential of using the sphincter as a fulcrum, you know, and then you will put some traction. You will put some traction on the sphincter. Okay. So here again, I'm doing the same thing on the other side. You see, I do these incisions. I don't mind if they are on the adenoma because they give me access to the better lateral plane here. I want to see if I can find a nice lateral plane that I can develop so we can go up and down. Remember that I think of the prostate as if it was a little box. So I talk about the posterior plane, the lateral planes in both sides, and then the anterior. This is the early apical release. It takes time, and it takes preparation. Basically, what I want to do is to mobilize the apex so it gets a lot of mobility, and this mobility is going to help me achieve reaching the 12 o'clock with minimal traction of the sphincter. This is what I'm going to try to show you. Here, again, I'm coming distal because I want to have the distal attachments of the apex to the sphincter and to gain a little bit more access to go anterior. Also, we have to have this exquisite care of the lines of dissection. You see that I had a posterior line. In this side, I have a lateral line of dissection, and I want to have these lines connecting. So I want to check that the posterior line that we had before here, you see, this posterior line is connecting now to the lateral line. And these lines are going to be important because they're going to allow me to get good orientation. So I'm coming out, you see, this is the 12 o'clock region, this is the apical part, so I'm following this white line that I marked at the beginning to guide my incisions. I don't want to leave any tissue there, but you see these original incisions are going to give me access to be able to follow, let's say, the lateral plane. Let me show you how slowly we can build up these lines of dissection that are going to guide us.
Yeah, we are seeing that. But can you tell me what is the specific very good advantage of this end block against the myeloma?
Question is that what is the specific advantage of end block?
Well, many advantages. Number one, visibility. As you can see, we see really well inside this cavity because it's a small cavity, so we are irrigating a very small space. If we find an artery, the artery will bleed, but very fast we will be able to wash out everything. I think I connected already anteriorly, you see? It was not difficult in this case. So now I'm going to work on my anterior line of dissection here. Let's see, this looks a little bit deep, so we need to be careful.
So what is the rate of stress incontinence in your cases now?
So we have a rate of stress incontinence of about 2 or 3%, and that goes away after 1 month. It's 2 or 3%. After 3 months, it's less than 1%. So I think it pays off to be very careful when you do the dissection of the sphincter. Careful dissection of the sphincter. So another aspect here is that, you see, I want to get to the bladder neck. You see that we have to go down here, but the prostate doesn't go down very well. So you see, as I said before, we have to gain mobility, we have to be strategic. So I'm going to release from the sides because sometimes these side attachments are going to make it difficult for us to lower the adenoma, in order to see the entry into the bladder neck. Another important advantage of the block, because there are many, it's incredible. You see, we know that stretching the sphincter is a problem. And you know, here I'm going to reach the bladder neck at 12 o'clock, above the anterior commissure, okay? So that's pretty high, okay? Pretty high. By experience, when you do a 3-lobe technique or 2-lobe technique, when you want to do the 12 o'clock incision, you will need to angle the scope very significantly, okay? That means that the scope is also producing a lot of traction on the sphincter. So you will see the moment I enter the bladder here, my endoscope is going to be totally horizontal. And you might think, why is that? I mean, why? Reaching the same plane conditions two very different positions of the endoscope. Look here, this is the entry into the bladder. I can tell because there are vertical fibers. So you see, I'm entering the bladder here. But if you look at my scope, it's absolutely
Yeah, I think
horizontal.
that point should be very well conveyed. That
Yes.
if you keep the stretch on the sphincter minimal, that goes a long way in prevention of stress incontinence. Majority of the operators, they fear and don't take up the procedure just because of the stress incontinence. So the bottom line is that you don't angle the scope too much.
Also, if you look at how I hold the scope, you see, I'm just holding the scope with my thumb. I'm not even, usually I use my fingertips on the camera to hold the scope, which means that I'm not doing any force whatsoever. I think you have to be extremely careful. Also, another advantage of the block is that when you have trouble entering the bladder at the beginning, you don't need to enter the bladder. You can start at the apex and enter the bladder later on at this stage. For example, in America, Amy Krambeck is doing perineal access when she cannot see very well when she cannot enter the bladder. So if she has a very large prostate with a big middle lobe and she cannot reach the bladder with the endoscope, she does a perineal urethrotomy to enter through the perineum and then tries to do the operation from there. But in my experience, we can start at the apex, there's no need to enter the bladder. You see that the orientation is quite simple because this is like the anatomy of an orange.
So that is what I was willing to ask Gomez, that when will you not do HoLEP? You have any contraindications for that? Or
No,
you have,
no, really.
what is your size limit? Do you do robot simple prostatectomy?
No, we have a robot. I do a lot of prostate cancer, radical prostatectomy, partial nephrectomy, cystectomy with a robot.
Size is not a limitation. I think that message must go to the audience that for doing HoLEP, size is not a limitation, but today in India, we have people who are doing robot simple prostatectomy for prostate anywhere above 250 grams. What is your take on that?
Well, in our hands, when we do 300 gram prostates, even 400 gram prostates, we can do it in one go. Usually, we can do it in one session, and patients go home probably the next day, often without catheter. So I think the robotic approach is probably not justified for someone who can do HoLEP. I think in America, there's also a lot of experience in robotics, and then people, let's say, desire to learn, to go through the learning curve in HoLEP, so they overuse, I think, robotic prostatectomy. Often you see people justifying the use of robotic for 250 grams, but then they use it for 100 grams or 80 grams, you know what I mean?
Sir, any comment on chances of urethral stricture in a large gland where you are keeping the receptoscope for a very long period of time?
Well, we try to keep the operations below 2 hours, 2 hours and a half in the very large glands, and our incidence of stricture is quite low, it's about 1%. So I think there is a chance of stricture also with the robot because you're going to keep the catheter longer. I don't know, I don't think, also, how do you say, some people try to find one single aspect that for him justifies the use of the robot against the use of HoLEP. For example, you get less stricture, so let's do, that's the reason why I do robotic, okay? But with robotic, you have abdominal hernias, you have abdominal problems in EVA, you keep the catheter longer. So you cannot just look at one thing and say, this is why I do robotic. Because if you do HoLEP, and for most people who don't do HoLEP, I have a little bit difficulty getting this angle. I'm going to try to slowly gain, millimeter by millimeter to see if I can go around this angle. So what people who don't do HoLEP don't realize is that HoLEP is a magical, true operation. You operate an old man with a catheter, he's 90 years of age, he has a lot of comorbidities, and the next day, he's walking home, It's amazing, even if he had a 200 gram prostate. So that means that it is a really amazing operation, and the more you do it, the more you get in love with it. So sorry for this. I'm trying to go from up to down now. If we can summarize the technique, I would say that I did a little bit of posterior dissection. Then I went from 6 to 12. So I went ascending, and then I did the anterior dissection, entered the bladder, and now what I'm doing is descending in both sides. You see, so basically what I want to do is to come now from 12 o'clock to 6 o'clock in order to communicate at 6 o'clock and finalize the procedure.
Yeah, I think we can see that the capsule is quite thin posteriorly and many places it is getting exposed. So what are your tips to the youngsters that they don't undermine the posterior zone? Because if you see...
Yeah, it's getting thin in some areas, but this is quite normal.
In your hands it's wonderful, but in a youngster's hand it could be troublesome.
Okay, what I did now is I tilted one of the lobes, you see, that will give me much more space down here. So basically, I discussed yesterday two things that the surgeon can do to modulate effect. We said that distance is one, we said that speed of movement is another one. You can choose the speed of movement. So with the same settings, two surgeons will have different effects depending on the distance, the movement. But there's another important factor, and this is the targeting. You see, we want to dissect this. If you target against the capsule, you see you're going to deepen more and more. You see the capsule is going to get thinner and thinner. So often you have to target close to the adenoma. Okay?
Yeah, I think that point is very valid, and all the people in the audience who want to learn HoLEP, at every stage you have to do course correction. This is very important because if you are just maintaining one plane, then you may perforate. So this course correction is an important point which Professor Gomez is explaining to you.
Targeting is fundamental. I think it's the most difficult to master. No?
Yes, absolutely. Undermining the trigone is the one complication which spoils the procedure. What in your book, Dr. Gomez, is when will you not do HoLEP? That would be important for the youngsters.
That's a difficult question because I don't know when would you not do HoLEP. I would never do HoLEP after brachytherapy, for example. Brachytherapy, I think it's very destructive for the prostate. The tissue has no chance of recovery. You know, if you do a HoLEP in a patient after brachytherapy, the wound will never heal. You know.
Very nice. I think
Beautifully done.
Beautiful this thing, and you all must appreciate the way it has gone.
Let me show you, because the most important aspect of this operation is how good you can preserve the sphincter. Look, when you look at the sphincter, you see.
Yeah, I think beautiful depiction of the sphincter. Absolutely no
see, we preserved the mucosa. Before we only saw the flap, and the flap was hanging from here, which means that all this mucosa was ripped off, and that's explained a lot of this early incontinence.
Tremendous, fantastic.
So I'm happy that I could show it properly today. Of course, we're going to see a little bit deepening.
Yeah, you can all appreciate these are all deepened stretching of the capsular fibers.
But you see,
And this is where he is doing the coagulation. So this is important. But what is your policy on patients where you cannot stop anticoagulants?
well, I am very careful with anticoagulation. I think you shouldn't buy the marketing from companies telling you that you can do patients on full anticoagulation and remove the catheter as if it was normal, because anticoagulated patients bleed a lot even after insert procedures. So I am very, very careful. I keep them very short of anticoagulation.
Do you still use green light for them?
No, not anymore.
And then what do you do for ones where you are not able to stop anticoagulation?
Well, I fight with the intensivists, I fight with the cardiologists to keep the patients a little bit short of anticoagulation, because that's the only way that they can recover without major complications. Huh? Probably similar to what you do. I think if you do a lot of cases, you start seeing that despite you could be lucky with one case of a patient who was fully anticoagulated and you did something and it went well, when it goes bad, you know, anticoagulated patients can exsanguinate with hematuria, you know. and they developed these bladder tamponades, and you have to go back to the operating room, and it all puts the patient on risk. So you need to be extremely careful. Keep them short of anticoagulation for a while, because there are two risks. The risk of clotting, for example, of the let's say metallic valve, which is life-threatening, and the risk of bleeding, which is also life-threatening. So I would be very, very careful.
So what is your experience with the thulium fiber laser? Have you used it?
Yes, I think thulium fiber laser lacks the ability to open the plane the way holmium does.
But
So
that is more coagulative.
the hemostasis is it's good. It's very good, probably better. Actually, I'm using Magneto. Magneto is the setting that is probably very, very similar to thulium fiber. You see, this is the Magneto setting. You can see there's even a little bit of carbonization on the tissue, typical of this.
So I think this must be appreciated by the audience, that this Magneto equipment has the potential for both holmium and thulium, and you change the settings and you can utilize the benefits of both the lasers in single machine.
Well, you know that the wavelengths of holmium and thulium are very similar.
Yeah.
So it's not a thulium. A Magneto is how do you say, a pulse that has the same length, the same duration as thulium lasers, but it uses holmium. And of course, the effect on the tissue is very, very similar. So we get quite reliable hemostasis. I'm being a little bit anal here, trying to get. There's a lot of edema on the mucosa, and as you know, holmium cuts by disruption, and the disruption of the mucosa often causes mucosal bleeders. Yesterday we had a problem with visibility during mortalization because of a bleeder here at the bladder neck, at the mucosa.
So what is your experience with Moses? Moses is a technology where they say that it is more hemostatic, more efficient.
Yes, Moses is a pulse modulation very similar also to virtual basket, which is what we have used today. I think it's really good, it's very good, but the limitation is the expense, because they use single-use fibers that are quite expensive. So with the Quanta laser you can use the fiber 10 times and sometimes more, especially in countries where you can use these liquids for sterilization. Help me now, where's the doctor? I need this one.
So any questions from the audience? I think the procedure has been done very well. Hemostasis has been achieved, and now Dr. Gomez is going to go with the mortillation.
Look at the water under my feet, it's full.
Yeah, so all of you can appreciate that it's a crystal clear urine. Irrigation. Can you show the fluid that is coming?
No, we can see, sir.
So it's absolute